Happy to stay with you here. My conference is not so inspiring, no, than the speaker has spoken before me. But I want to explain, maybe it's possible to put the first slide, okay? Okay, I want to explain about the situation we have in Catalonia. We have started a process more than 3 years ago. We have started with a chronic care program because at the Department of Health, they wanted to go forward with another kind of integrated care model. And after 2.5 years, we have started to work in some kind of integrated health and social care. We are starting at this moment, and we are taking the first decisions during this year, but we have the experience of these 3-4 years working in this kind of chronic care program. Okay. You could see here, no? For example, it's some basic information about the situation in my country. We have a national health service. It's very similar to the situation you have here. We have a lot of decentralization. I think we have a lot of autonomy and competence of Catalonia to organize the services, no? In a very different way to the rest of the country. We have free access, universal coverage. In this way, it is a very similar situation you have here. We have some kind of co-payments in the case of pharmaceutical products, and we have a lot of autonomy and competence to develop these kind of services in a different way. You could see the challenge we have in our country because we are in process of an intense aging. You could see at the middle of the century, we will have about 1/3 of the population over 65, and we will have over 12% of the population over 80, and you could see the situation, maybe it's very similar to the situation you will have here in Finland. We have the same challenging issues. The most important indicators, we are not in a very bad position. I think we have a Mediterranean style, and I think maybe it's the cause of this kind of good indicators about life expectancy and mortality rates and infant mortality. And you could see more or less what kind of organization we have in Catalonia. We have almost 370 primary health centers. They have a population attached. I think it's in general terms very similar to the situation you have here. Maybe the health centers in Catalonia are bigger or larger than here, but it's very similar to here. We have almost 70 acute hospitals. We have more hospitals than here. Maybe it has not been a very good solution in Catalonia. I think you have here 20 hospitals, and I think the situation is better than in our country. And you could see different kind of services. No? For example, in the case of long-term care and mental health centers, we have a network of services related to this kind of thing. Okay, the starting point, it is the new health plan. We are at the beginning of a new period in Catalonia, at the beginning of 2011. At the final of 2011, we have established this kind of health plan. I think it's very important because we have focused not only in the targets and objectives to be achieved in the next 4 or 5 years, but also the most important focus, it is about transformation. And the first decisions and the most important focus, it is established in this kind of, some kind of orientation to chronic patients, to strengthen the role of primary health care to cope with this kind of chronic care, and to make some kind of reordination of tertiary care. But it's not all important, this kind of the transformation of the provision, but also to change this kind of instruments, because in the past we have different kind of contract with targets for primary health care, a different contract for hospital care, another contract for long-term care, and another contract for social care, long-term care, and mental health facilities. The most important thing is to change these things. We have introduced some kind of common and transversal targets to different kind of lines we are working in Catalonia. And another important thing is to change all the strategy to share information between health and not between health and social care. I think it's very important not only to think in terms of provision transformation, but also this kind of instruments to change all the things in Catalonia. you could see we have focused in this kind of strategic lines. We have started with this kind of single disease approach, but we have changed it along the time to have more focus in multimorbid, complex chronic patients, especially people with multimorbid conditions and patients with advanced chronic disease. We have focused in this kind of area because in some cases we have started to design integrated care pathways for heart failure, but we have noticed some of these patients, they are in this kind of situation. They are complex chronic patients, and we have evolved during these years to this kind of situation. You could see that this is a picture of the model we have designed, and here it's very important. We have made this kind of differentiation. We have differentiated between complex multimorbid and advanced chronic disease. The idea of to cope with this kind of advanced chronic disease, it is to focus in some kind of advanced chronic disease requiring palliative care orientation. I think the idea is to identify this kind of patients, this kind of people, to cope proactively in this kind of thing, because we have a long experience in oncological patients, but the idea is to introduce this kind of proactive care for this kind of advanced chronic disease. The most important thing we have started to perform, it is we have established integrated care pathways at local level. The integrated care pathways, we have a big difference between clinical guidelines and integrated care pathways. The idea of integrated care pathways is that one, I think, to establish at local level, at county level, at city level, some kind of agreement about these kind of situations. What happens with the diagnosis? What happens when you are in front of an acute exacerbation, not only during the morning, but also in the evening, at night, and during the weekends? I think it's very important to establish this kind of 24/7-day warranty. And what happens with you have management difficulty and transitional care? For example, when a complex patient is in the hospital, is being interchanged, is coming back to the community. Okay, the first decision we have taken, we have go to the international classification we have, and we have noticed we don't have any kind of classification of multimorbidity and advanced chronic disease. The first decision we have taken is to establish this kind of label. We have established every professional could put in the local health information system this kind of label, this kind of mark. If you put this kind of label, this kind of mark, it is some kind of ad hoc mark. This kind of mark go up and upload to the cloud, to the shared clinical record. We have a shared clinical record. I think it's very similar to the CANTA project you have here in Finland, and you could see this kind of information is going up, and we put this information to be seen for everybody who is working with this kind of patients. Okay, another important thing, it is related to this kind of mark. We have established this kind of key information summary. For example, this kind of patient, we have some basic information is going up, this uploading automatically, but some information, it is in a narrative way. For example, with advanced chronic disease, I think it is recommended to make some kind of advanced care planning. In the way, if you are in front of acute exacerbation, and the patient or the family is calling to the call center at night, you could see this kind of label on the screen, and you could see this kind of key information summary. I think it's very important because that is the best way to take the best decisions out of hours for this kind of patients and people. Okay, you could see we have started step by step, and we have in Catalonia about 7.5 million of people, and we have market in this way over 120,000 people with this kind of mark. It is about 1.5% of the population under this kind of condition. You could see that is a project very similar to CANTA. We are sharing this kind of information. We have information of primary health care, specialist care, and diagnostic procedures, different kind of electronic prescription. I think everything is in the electronic health record. You could see what kind of involvement of the different kind of lines to publish information and data in this kind of electronic shared care. And you could see here most of the providers, they are publishing this kind of information in this kind of electronic share record. And you could see some kind of figures about this kind of thing. It is over 20 millions of documents published per year. I think that's the situation we have there. Another important thing, it is about the stratification. We have started between 3-4 years ago with this kind of thing. Very important thing we have established, because in the past we have only this kind of minimum data set in the hospitals, and we have regulated for every provider, it doesn't matter if you are public or non-profit private working for the public system, to deliver every month this kind of basic data and information related to this kind of minimum data set. And we have a central unit at the Department of Health to have this kind of basic information of the minimum data set of hospital, primary health care, mental health, long-term care facilities and nursing homes, and emergency services and pharmacy. This kind of information is being aggregated, and we could produce this kind of pictures. I think we have bought some kind of commercial solution. It's called Clinical Risk Group, CRGs, from 3M Enterprise, and we have worked in this way. You could see the distribution of morbidity and chronic morbidity with the population of Catalonia. You could see the darkest one, the more multimorbidity you have. We have this kind of picture, but it's possible to see this kind of picture not only at regional level, but also at primary health center level. For example, the director or the manager of a primary health center, it's possible to see this kind of picture compared with the picture of Catalonia and to see what kind of difference you could see. And it's possible, for example, to see this kind of pictures. For example, that is the picture of the people in Catalonia who has at least heart failure. And you could see the level of multimorbidity, the darkest part of this kind of picture. You could see what kind of distribution according to age and sex, and the same for COPD, and you could obtain this kind of images at local level also. Okay, the idea is, in some cases, we could see people with 2 chronic conditions in health status 6, with a lot of severity. They have more probability to be admitted in the hospital than people with 3 chronic conditions with less severity. I think it's very important, because with this kind of stratification, it's possible to distribute the different kind of risk of the different kind of segments of population. You could see the distribution of this kind of population. You could see the different kind of segments according to the proportion of population, and the different kind of mortality rates and hospital rate, and the estimate expense about this kind of segments. Another important thing, it is to publish this kind of information. For example, we have on a score, we have the typification of the clinical risk. For example, if you are in the group 7.5, you put in the screen of the clinical record. And also, we have published this kind of score of risk to be admitted in the hospital in the next year, and the risk to die. And the idea is to establish some kind of clinical assessment about the possibility you are a multimorbid patient or you are in advanced chronic disease condition. I think it's very important to show this kind of thing. And another important thing is not only to show this kind of information in a flat way, but also to have the possibility to make some kind of queries. We have, for example, in Catalonia, you have the general practitioner and the community news has an attached population, for example, of 2,000 inhabitants or less than 2,000 inhabitants. It's possible, for example, for the general practitioner, for the family doctor, to say, I want to take a list of the patients who are in home care with COPD and with this kind of risk to be admitted in the hospital. And it's possible to have a list to be proactive in this kind of managing this kind of people. Another important thing it is we have worked for 4 years with the clinical risk groups, but we have created our own homemade model of stratification because we have the experience of these 3 years, and we have worked in some kind of Catalan stratifications. We have an agreement with the Department of, with the Ministry of Health in Spain, in Madrid, and the idea is to spread this kind of local and own homemade stratification to the rest of the regions in Spain. The idea is if you are working with series, it is a very black box algorithm. In our case with GMEAs, we have an open source algorithm, and it's possible to introduce some kind of social determinants. In the case of the series, for example, it's not possible to put some kind of variables like living alone, or some kind of social variables. I think the idea is to introduce progressively in the GMEAs this kind of social determinants, not to adjust this kind of thing. Another important thing, it is about evaluation. We have, I have mentioned before about the possibility to introduce some kind of common and transversal targets for primary healthcare and hospital care. You could see here some examples. For example, that is a dashboard where the general practitioner and the community news who has a population attached, it's possible to see monthly the results and the score in different kind of indicators related to chronic conditions. For example, good control in diabetic patients, good control in hypertension patients, different kind of good treatment in heart failure, different kind of things. You could see what is the performance of every clinician compared with the rest of the clinicians in the whole system, and you have this kind of feedback every month with a delay of 1 month, 3-4 weeks to have and to see this kind of results. You could see some of the indicators we have. We have started in 2007. You could see with the same indicators what is the evolution, the same in this kind of indicators, for example, multidimensional assessment in home care. We have this kind of data aggregate. It's possible to know for all Catalonia, for all regions, for all districts, and for every practitioner according to the population who is attached for every professional in a benchmarking process. Okay, another important thing, it is about the emergency admissions. We are working to cope with this kind of thing. You could see here we have different the most important causes of emergency admissions in Catalonia. Maybe here it's the same, it is heart failure and COPD. We have this kind of distribution. Here you could see there are different kind of counties. We have over 30 counties in Catalonia. You could see what is the distribution of the rate of hospitalization related to chronic conditions, and you could have this kind of comparison. You could see what is the situation. We have worked with the American Health Research and Quality Indicator related to avoidable hospital admissions. We have the formula they have used, and we are calculating in this kind of population base. It's possible at county level, and it's possible at primary health level in a population base to have and to see this kind of information. For example, you could see that is a composite indicator, no, for different kind of accumulated chronic conditions that is related to COPD, and you could see that is over 200 admissions per every 100,000 inhabitants per year. That is the rate we have, and we have that is a general rate for all Catalonia, but it's possible to go down and disaggregate this data. For example, it is the same in the case of heart failure, and you could see, for example, that is information of one of the best counties we have in Catalonia, where we are working in an integrated health and social care model with a very good social care position. You could see here the results of this kind of county. For example, Garrotxa, it is this county, and you could compare with Catalonia, that is the line of Catalonia, the line of Garrotxa, and you could see what is the rate of emergency admission related to COPD. And here you could see after adjustment, because according to the structure of age and sex, you could adjust this kind of information, and you could see what kind of evolution you have according to one, and you could see after adjustment what is the situation of confidence intervals. The same, we have this kind of benchmark. Here you could see the different kind of regions, and you could see here what is the situation of Garrotxa County in Girona area comparing with the rest of the situation. I think it's very important because we know this information with a delay of 5 months, because we are collecting all the information of the minimum data set of hospitals we analyze, and we are returning to everyone this kind of information. The most important thing it is a manager of a primary health center has the same target as the hospital care. And that's a driver to work together and to be in the same table to work and to discuss about, for example, if you have an higher standard of this kind of objective, this kind of target, it is expected to go to the table and to discuss how to improve this kind of thing in the same level with the hospital, long-term care facilities, and the different kind of providers and agents you are working. We could perform different kind of work. For example, it is the distribution of costs in the people who has at least heart failure, the distribution of costs with the people who has at least COPD. For example, that is the cost of primary healthcare, the cost of pharmacy in primary healthcare, and the cost of hospitalizations, the red one of the people who has. It gets very interesting because you could see and you could imagine the different kind of distribution of this kind of cost. The next step we are working, it is about the integrated health and social care model. It's called PAs. We have started last year, and we have the first steps. It's a very difficult work. It's a difficult step-by-step work. That is an image of the model we are implementing. You could see here the first idea. We have two administrations, a local level, not only a regional level, and the idea is how to create this kind of governance, not at the top, but at meso and micro level in this kind of things. And you could see how to create this kind of microsystems. We have experience to create this kind of pathways in the past, and the idea is to incorporate to the social services in this kind of pathways. What about to have some kind of shared needs assessment and action plan, to introduce some kind of social variables in this kind of stratification model, to have some kind of a shared outcome framework, what kind of indicators we would use, no? To have a common and transversal objectives and targets in a territory where it is expected, no? The social and the health services are working together and working to each other. And one of the things we are trying to go forward, I think here we have the experience of Aulu and South Karelia, you are working in these kind of things. We are very committed, no, to progress in this kind of thing. The first decision we have taken, because in the past we don't have this kind of decision, is to have the same identification number. Another important thing, it is in the case of social services, we don't have any kind of international classification of social problems. We have problems within Catalonia in Spain to have an international or national classification of this kind of social problems, and to have this kind of codification and standardization of this kind of information. And another thing, it is the incorporation of social variables and different kind of plans to be shared in this kind of electronic shared health and social care record we want to transform. For example, we are working with the city of Barcelona. We have established some kind of agreement. We have written down this kind of agreement to share some kind of basic information of common interest to be shared between the social workers and the health professionals. In the case of the agreement, it's easy. We have started to write down this kind of agreement, and we are signing without problem this kind of agreement. But the problem it is with the legal barriers. We have legal barriers and restrictions, and the way we are progressing, it is to have the person consent to facilitate the possibility to share this kind of information. I think we have committed to ask for the person to have this kind of consent, and if the person has this kind of consent, it's possible to share and to show in a dashboard this kind of information. Okay, you could see here what kind of information we want to share. That's the most important key information to share, the diagnosis, the complex chronic conditions, the shared individual plan, the different kind of variables. For example, you make an assessment in primary healthcare and you make another assessment in social care about Bartel index, cognitive impairment, social risk, and the idea is to share these kind of variables, this kind of data, to avoid the duplication of tasks in the field. And the same in the case, for example, we have in Catalonia some kind of formal recognition of dependency degree, and we are sharing this kind of information in the same shared electronic health and social care model. For example, if a patient or person is in some kind of home care, home help, telecare services, and the plan in the case of social social services. That's the idea. The idea is by consent. I have explained it about this kind of thing. And the next step is how to perform some kind of joint assessment plan. I think it's very important to establish some kind of decision about this kind of joint assessment plan. We are thinking about two possibilities. One possibility is to take on to explore the possibility to adapt the inter-RAI or RAI tools to the field. Some social workers don't feel confident about this kind of thing, and the idea is to explore and to take a final decision between this kind of tools, or to create some kind of shared assessment tool to be performed by social or health professionals together for the same population. And another important thing, it is about a second version of this kind of key information summary. We are working in this kind of second version of key information summary, the same. Some information automatically go up to be shared in a 24/7-day scheme. There are a multidimensional assessment to take this information and to put together in the cloud in this kind of shared electronic record. And the same, for example, you have different information about social services, for example, living alone, and information about the last emergency admissions or visits to the emergency and accident department. Okay. The last thing it is we are working in some kind of platform, because we have a good experience to share information, especially in healthcare. But the next step is to communicate, to exchange this kind of information, to have a platform to facilitate communication between health and social care. And we are working in some kind, we are developing now in 2 territories, and maybe a third in Catalonia, this kind of 360 degrees person vision. The idea is, if I am working in primary healthcare, I could see what happens and what kind of utilization of services in hospital in another kind of services in social care, to have this kind of overall holistic vision of this kind of services utilization, and to have some kind of collaborative environment to make this kind of assessment plan and intervention plan. Till now we have different and silo assessment plans in different kind of information system, and we are working with IBM and other 2 partners to work in this kind of thing. Okay, the same with integrated care pathways. We are working to define, to design, and to modelize this kind of pathways in this kind of platform. And another interesting thing, we have opened steadily, as you have had here in the CANTA project, this kind of personal health folders to facilitate communication between the citizen and the professionals. Okay, that's all. That is the final picture of the model we are developing, and I am happy to answer questions. I have the panel after, and we could discuss about the things I have presented now. Okay, thank you very much.